right, let's go ahead and get started. Welcome, and thank you for joining us today for our webinar on the community-oriented occupations in public health. My name is Janette Dill. I'm from the University of Minnesota, and we're going to introduce all of our speakers for today in just a minute. Today's webinar is part of a three-part series focused on CHWs. One has already happened. It was hosted by NASHP yesterday, but one is directly after this one and is hosted by the Center for Community Health Alignment. And Chelsey is going to put the link to the registration for that webinar, which again follows immediately after this one, in the chat. So we definitely encourage you to join.
So a couple quick session guidelines. Would encourage you to use the Zoom Q&A window to ask any questions. Most questions will be held until the end of the presentations. Presenters may respond to some of the questions in the Q&A window during the program when they have completed their respective sections. Please feel free to use the chat to message the host about any technical issues, and closed captioning is available for this webinar, and those settings can be accessed in the Zoom application toolbar on your screen. After the webinar, all of the slides will be emailed shortly to all attendees, and audio and video of this webinar will be recorded. A link to our YouTube channel will also be shared in the follow-up email. You can subscribe to our email list to receive alerts about additional webinars and projects. The link will be posted in the chat. I'm going to take a time to briefly introduce all of our speakers today. We have three presenters from the University of Minnesota: Janette Dill, myself, Chelsey Kirkland, and Hank Stabler. We are part of the Consortium for Workforce Research in Public Health, and we will provide a little bit more information about that group in a moment. We are also thrilled to have two public health professionals here today to talk about community-oriented workers in their particular counties. Bree Allen is a public health supervisor at Nicollet County Public Health and Human Services in South Central Minnesota. She has experience in both state and local public health and is particularly focused on addressing the unique challenges faced by rural communities. Bree holds a master's degree in public health administration and policy from the University of Minnesota. Leah Roberts is a public health professional and doctoral level nurse. She has worked at Dakota County Public Health since 2010, in which she has worked as a home visiting nurse, emergency preparedness coordinator in her current role as a public health supervisor for emergency preparedness, emergency medical services, and community engagement, which includes a team of 6 community health workers. She holds a Bachelor of Science in Nursing, a Bachelor of Arts in Spanish Studies, and a Doctor of Nurse Practice in Public Health, all from the University of Minnesota.
Right, so you might have noticed in our title that we're using the term community-oriented workers, and you might be wondering exactly what we mean by that. Community-oriented workers include community health workers, so CHWs, and health educators, as well as peer counselors, navigators, and outreach specialists. These workers play an essential role in delivering population-based services across local and state health agencies, as they are often the frontline providers of culturally responsive care, outreach, and health education to underserved communities. And we'll explain a little bit later why we are using a broader term instead of focusing more narrowly on each occupation. The goal of the webinar will be to provide an overview of the community-oriented workforce in local and state health departments, and we will include examples from 2 departments in Minnesota describing the roles and job tasks of their community-oriented workers. I want to note that while the University of Minnesota folks, UMN folks, are going to be talking more broadly about community-oriented workers, both Bree Allen and Leah Roberts are going to be talking specifically about CHWs, community health workers. All right, so the University of Minnesota is going to start us off, and we're going to talk about job quality and the distribution of community-oriented workers in local and state public health. This work was supported and conducted as part of the Consortium for Workforce Research in Public Health. CWORPH is our acronym. CWORPH brings together top research teams from 6 universities to conduct research in the areas of public health workforce and systems, and these are the universities listed here. CWORPH is the home of the HRSA and CDC-funded Public Health Workforce Research Center, the only health workforce research center that focuses specifically on the public health workforce. It is also funded by the CDC National Partners Cooperative Agreement to support recruitment and retention in local public health departments. And this is the grant that supports the work that we're presenting today. All right, so our project goal I'm sorry, I'm going to hand that over to Chelsey to talk about our project goal.
Thank you. Absolutely.
Kept rolling right there.
So this project, despite the growing recognition of the importance of community-oriented workers in public health, which includes community health workers and health educators, there's limited data on distribution and job quality of this workforce in local and state health departments. And so some of our questions included, how large is the community-oriented workforce in public health? Where is this workforce employed? And then how does job quality for this workforce compare across settings?
Oh, dice up. Shoot. Okay. Apologies, it's being a little sticky. Okay, there we go. We use 2 data sources for this project to learn about the community-oriented workforce in public health. The first was the American Community Survey, which is administered by the U.S. Census Bureau, and we looked at trends between 2019 and 2023, so a 5-year period. In the American Community Survey, which the acronym for that is the ACS, and we'll try not to overdo it with the acronyms, but we identified community-oriented workers through occupation codes. The census occupation codes group CHWs, health educators, and other community-based workers together under one single code. So we're not able to look at these occupations separately with this data source. So this is one of the reasons why we refer to the community-oriented workforce rather than pulling out specific occupations. The advantage of the ACS, however, is that it's a nationally representative survey. It's the biggest and most comprehensive federal survey in the U.S., and it allows us to compare community-oriented workers in local and state health departments to community-oriented workers that are practicing in other settings like clinical healthcare or community-based organizations. So there are some limitations to using the ACS, but there are also some significant strengths.
We also used PHWINS for this work. PHWINS, or the Public Health Workforce Interests and Needs Survey, is a nationally representative survey that collects detailed information on the U.S. public health workforce, focusing on employees in state and local government public health agencies. It's conducted by the de Beaumont Foundation and the Association of State and Territorial Health Officials, or ASTO. The survey provides insights into workforce demographics, training needs, job satisfaction, and workplace perceptions. It's the first and only survey of its kind to represent both state health agencies and large, medium, and small local health departments across the country. And so for this work, we used data from the 2021 and 2024 PHWINS.
All right, so let's just jump into some data here. Here we draw on the data from the ACS and show trends from 2019 to 2023 and the number of community-oriented workers employed at the state and local level in public health, as well as the percentage of the total community-oriented workforce that they comprise. So we find that from 2019 to 2021, the number of both state and local community-oriented workers increased. with workers employed at the local level, that's the blue line, experiencing a sharper rise, peaking at around 13,000 in 2021. State workers, which are in red, peaked in the same year at just under 10,000. After 2021, however, the number of workers in both settings declined steadily through 2023. Despite fluctuations, local community-oriented workers consistently outnumbered their state-level counterparts from 2020 onward. The percentage of community-oriented workers employed in public health versus other settings like hospitals or outpatient clinics or things like that. So the total number of community-oriented, or the total percent of community-oriented workers in public health peaked at around 13% in 2022, but then declined to around 10% in 2023. But as you can see in the figure, it's the green dotted line, it remained fairly consistent.
So for this graph, we drew on data from PHWinds, and it shows employment trends from 2021 to 2024 for public health workers at local and state levels across 3 community-oriented occupations. So community health workers, health educators, and other community-oriented workers. Local employment increased with notable growth for community health workers and health educators, which saw an increase of 26% and 15% respectively. In contrast, state employment either declined or grew modestly. Health educators at the state level saw the sharpest drop of about 43%. The other community-oriented workers category remained small, but it showed gradual growth in both local and state sectors. And overall, the data indicates a shift towards increasing reliance on local public health workers. So while absolute numbers in PHWinds are smaller, which reflects the survey's targeted sample of governmental agencies, the trends do align with our ACS findings at the state level. So sharp reductions in state employment, particularly among health educators. At the local level, however, PHWinds shows growth in both CHWs and health educators between 2021 and 2024. This divergence from ACS trends likely reflects methodological differences. So PHWinds is designed to directly capture the governmental public health workforce, while ACS classifies workers based on industry and occupation codes that tends to capture a broader group. So together, these data allow us to confidently conclude that state public health employment of community-oriented workers has contracted significantly since 2021, while local employment trends remain less clear.
All right, so this map shows the distribution of community-oriented workers in local and state health departments based on data from the ACS. Interestingly, the largest percent of workers, community-oriented workers in public health, are located in the South, followed by Western states. So nearly 40% of community-oriented workers that are employed in public health are in Southern states. Around 14% of community-oriented workers are located in rural areas. Here we show trends in average annual inflation-adjusted wages for 2019 to 2023 for community-oriented workers in public health and non-public health settings. So from 2019 to 2021, wages increased for both state and local public health workers, peaking in 2021 at around 60,000 for state workers and around 50,000 for local workers. After 2021, wages declined sharply for both groups, and this really reflects the impact of inflation on wages. It's not like people were actually taking pay cuts. It was just that inflation was eating into their earnings. In contrast, wages for non-public health workers, this is the green dashed line in the graph here, remained relatively stable over the 5-year period, hovering just below 50,000 with only slight fluctuations. By 2023, all 3 groups had nearly converged in wage levels, with non-public health workers slightly surpassing both state and local public health workers.
One of our most striking findings is the substantial increase that we saw in professional certification among CHWs, whose certification rates actually rose from 29% in 2021 to about 47% in 2024. This trend likely reflects this growing professionalization of these roles as more states establish credentialing pathways. In contrast, certification among health educators actually declined about 9.2% between 2021 to 2024 to around 17%. In the PHWinds data, job satisfaction generally improved across groups between 2021 and 2024, with declines in the share reporting neutral or low satisfaction, and then corresponding increases in those reporting satisfaction. Again, those are significant. The share of CHWs considering leaving their jobs decreased modestly, from 26% to about 22%. Again, that's a significant decrease, while rates among health educators and other workers remained relatively stable. Finally, measures of mental and emotional health improved slightly as well, particularly among health educators, where the share reporting fair or poor health fell from 24% to 18%.
All right, so we wanted to wrap up with just a brief summary of our key findings. So first of all, we found that the community-oriented workforce in public health did expand quite substantially following the COVID-19 pandemic, but we see some evidence that the workforce is now contracting, especially in state government. We're going to have some time for questions at the end. We're very interested to hear about the experiences of those on the call and whether or not that resonates. We found that earnings were higher in local and state health departments as compared to non-governmental settings, so in clinical settings, especially during the pandemic, but that wages came down among public health workers and converged with non-public health settings in 2023. And then we found a dramatic increase in certification among CHWs between 2021 and 2024. Clearly, there's been a real push for credentialing in this occupation. And then finally, we found some modest improvements in job satisfaction and intent to stay since 2021. I think it helps to not be working during a global pandemic. I think that's reflected in the responses of workers. All right, so thank you. This concludes the University of Minnesota component. If you want more information, please visit our website, which is listed here. And then if you're interested in some of the data that we presented today, you can find a lot of it in a very concise format. We have a community-oriented worker infographic, and there's a link here on this slide, and you can access it there. And now I'm going to hand it over to Bree Allen, who's going to talk about CHWs in Nicollet County. Thank you, Bree.
Yeah, no problem. Thank you. Really excited to be here today to share my experience in South Central Minnesota. So recognizing that this is a national audience, I thought I'd just do a little bit of context sharing. So you can see there where we're located. We're a county of 34,000, slowly growing year after year. We're partially urban, partially rural. One of our major industries is manufacturing. Fun fact, we are home to Boom Chicka Pop, if you're familiar. Otherwise, previously known as Angie's Kettle Corn. Angie grew up in North Mankato, or had a home there. We have two higher ed institutions. A photo of them, one of them is here, Gustavus, and we are on ancestral Dakota land. Like many counties in outstate Minnesota, Nicollet County is becoming increasingly diverse. The proportion of non-Hispanic white residents has declined steadily over the last decade, which is a trend that's projected to continue. Our area has welcomed refugee and immigrant populations, including East African or Somali refugees, And our Latino population continues to grow, with recent migration including families from Central America, particularly Guatemala, and a lot of our newer residents speak Quiche, a Mayan language. Next slide, please. Thanks. So we posted for our first CHW position in 2020. We were preparing to administer, for us, a large number of COVID immunizations that was going to be starting in January of the following year. The position is situated within our public health team, which is part of a larger Health and Human Services department. Though, as I'll explain later, CHWs also serve a broader function in our department. At the start of the pandemic, we saw how essential trust and relationships were to effective public health work. Information was coming at an alarming rate, and we knew there were parts of our community that we weren't reaching well enough, particularly those underserved or disconnected from traditional systems due to barriers like language. The CHW role became our bridge, someone from the community who could help us listen better, build trust, and connect people to information and services. Our first position did require, when we posted it, that the applicants be bilingual in English and Somali. The first year of the role was largely centered around COVID information dissemination, connections to our vaccine clinics, providing essential services. Lula, who's shown here top left, she was our first CHW. She was instrumental to the success of our efforts that year. One of the main reasons we had so much success reaching a broad swath of our community. We were able to administer 10,000 vaccines, which for us was a good number, and a good portion of those going to historically underserved community members. And at times, over half of some vaccine clinics were attended by community members who were non-English speaking. We added our second CHW position pretty quickly after that. We realized the value of hiring Lula and the fact that we were still struggling to meet the community where they were at, especially those who were Spanish speaking. So that's when we brought in Anna, who's shown here on the bottom right. And right away, we were building new connections and relationships with our community, utilizing communication channels we had never used before, like WhatsApp, and making sure all of our outreach was in multiple languages and formats for accessibility. Next slide. So a lot has changed since 2020. This is a visual of our current state. We adapt as needed. We're a smaller county, so we have the luxury of doing that. Sometimes funding, team capacity, and needs in the community direct where we're spending our time. But for right now, about 40% of our CHW's time is direct service delivery. So that includes home visiting. As COVID vaccine efforts slowed in 2022, we took the opportunity to reimagine how CHWs could better serve our community. And at the time, our home visiting program was primarily serving English-speaking and privately insured families. So adding 2 bilingual community health workers opened the door to families we hadn't previously reached. And then we adopted the Healthy Families of America evidence-based home visiting model that uniquely situates CHWs as home visitors. And then I was looking at data recently, and in 2022, about 12% of our home visiting clients were non-English speaking, and by last year, that number has grown to about 40%. About 30% of their time is connecting the community to our public health and human services department. I've worked in a county environment now for almost a decade, and I still struggle to really navigate the system. It can be really complicated. So part of their role is systems navigators, connecting residents to not only health and human services, but the rest of the county. So for example, passports, where do I go? What do I need? They can help community members navigate that process. They can partner with case managers to explain diagnoses and treatment plans in culturally responsive ways. And they can provide us with feedback that leads to service delivery changes within our county to improve accessibility. And then the last 30% is addressing community identified needs. Our CHWs know best what's going on in the community. And so they're often on the front lines of recognizing community need. For example, a few years back, we were hearing from our CHWs in schools that childhood immunizations were really hard to find for some families. So now we've partnered with the local FQHC in a free clinic in town, and our CHW attends that and is able to provide some warm handoffs. Next slide. So we use a blended approach to fund our CHWs, and as is normal in public health, local public health, funding sources ebb and flow. Right now, we have a combination of local funding, so local levy supported by Nicollet County General Funds and other local resources. We do bill for home visiting under HFA. We are able to do that. The state of Minnesota has a CHW certificate program, which allows CHWs to become enrolled providers and bill for services. And we don't require a CHW certification upon hire. So if someone applies without it, we make sure that we can get them signed up for the next cohort. And then we're able to bill for home visiting services under the supervision of a public health nurse. Only about 30% of their activities is billable. So it's a pretty small portion of our overall funding, but anything helps. And then we have some grant funding. So mostly state grants that help sustain CHW efforts. Even though most of their time's in like our family health team, we recognize the benefit of having their insights in our emergency preparedness and response activities as well. So they're embedded across the team. Next slide. So just some quick numbers. Again, we're a smaller county, so these seem really great for me. Might not seem like a lot for some people, but last year, our 2 community health workers had 299 home visits, working with 104 clients. They distributed 8 car seats. They also become child protection, CPSTs, so certified child passenger safety technicians. So they administered a handful of car seats and cribs, and then do offer WIC grocery store tours as well, helping families feel more comfortable using their WIC benefits. And I'll just note here too that I'm actively trying to figure out better ways to measure our outcomes. There's actually a lot of work happening across the state right now to set some standards around like how do we measure the impact in a way that's meaningful. So these are fun numbers, but I'm looking for, there's more work happening to make sure that I'm capturing things that I'm not currently able to capture. And next slide. And then I just have a few lessons learned that I've gained over the last few years. And despite them being specific to CHWs, I think they can apply to many different types of community-based workers. The first being, and I've learned these the hard way sometimes, clarify the role and keep clarifying it. Make sure everyone in your organization understands what that role or for us CHWs do and what they do not do. I revisit this every year at a staff meeting. We've added it to our orientation, onboarding procedures. I have written procedures so staff can easily reference how and when to engage CHWs. If your CHW is bilingual, it's especially important to set boundaries around interpreting and translation. It's outside their job duties and can detract from their primary work. And it's important to not only tell this to your team or department, but then to tell the rest of your agency, depending on how you're situated. Because for us in a smaller county, word travels fast and misconceptions can spread quickly. So proactive communication helps prevent burnout for CHWs, having to constantly explain what they do, why they're there. It also helps guard against tokenism, ensuring that the CHWs are valued for their full skill set, not just their language or their cultural background. And then this last bullet, I'm especially passionate about supporting your staff. I've learned a lot about this over time. Anna, Lula, Cal, all of the CHWs we've had can attest to this. It's incredibly important to support the CHWs because they're in very vulnerable positions sometimes. Some of the ways we do this include routine reflective supervision with a contracted provider, ongoing training, consistent peer support. I also want to point out that the toolkit, a CHW toolkit developed by the University of Minnesota, I think Chelsey and Janette were both part of writing that with NACCHO, is really helpful. So if you haven't seen that yet and are interested, please take a look. They have some good information about how to support CHWs. And I also just want to acknowledge what many of our clients and staff are experiencing right now in Minnesota. CHWs and other community-oriented staff are uniquely positioned. They hold trusting relationships with clients that help people stay connected to services. And lately that has included people in our community supporting them with basic needs like food and access to care under conditions of heightened stress and fear, which means our CHWs are getting exposed to quite a bit of trauma right now, facing emotional and psychological strain. So it's especially essential that we be mindful of their well-being and help them maintain healthy boundaries, just so that they can stay in that role of CHW. All right, I think that's all I had. I can pass it over to Leah. Thank you.
Thanks. All right, our next presenter is Leah Roberts from Dakota County. Thanks, Leah.
Yes, thank you. I'm excited to be here today. Hello, everyone. As I said, I'm Leah Roberts. I supervise a team of CHWs at Dakota County Public Health. Next slide. So similar to, oh no. Similar to, I'll just talk through what was on this slide. I don't know what happened. But we're located in the Twin Cities metro region. Our population is about 453,000. So we're the third largest county by population in the state of Minnesota. We have a county seat that's actually kind of in a more rural part of our county in Hastings, but we also have two service centers, one in West St. Paul, which is an urban part of our county, really close to the St. Paul border. And then also we have a county service center in Apple Valley, which is in the suburban part of our county. So as I've just alluded to, we have urban, suburban, and rural, with the majority of our population residing in suburban areas. Our population is increasing, increased by 10% between 2010 and 2020, when the state only increased by 5% at that time. So we're getting bigger and bigger. Next slide.
And also, Leah, I don't know what happened to this slide, but if we continue to have problems, it doesn't look like there's problems with the next one.
Okay.
Then we'll just switch.
Okay. That's fine. I have them up. So
okay.
I'm glad I had them up. Yes. All good.
All right. This one looks fine.
This one looks fine. Yes. Just a little more about Dakota County for some context, similar to what Bree shared about Nicollet County. Our county is becoming more diverse. So as of 2024, you can see we're still majority white Caucasian, with BIPOC communities making up about 28% of our population. However, we have seen that increase over the past years. So and the state demographer has projected that our population of color will increase by 31% between 2020 and 2030. And the white population is expected to decrease by 4% in that same time. We also have an aging population, like many of areas across the United States. And so, as you can see, we're, pretty large percent 65 plus, and that will increase over time. Next slide. And just a little bit about our household income. A lot of the people we serve typically fall within people who meet eligibility for medical assistance, SNAP, cash, and WIC. But we do serve our entire population. And as of 2022, about 6% of Dakota County residents had incomes below the poverty level. With about 18% of children, I misspoke, 7% of children under 18 living below the poverty line. Next slide. So here's these are a couple people from our team, but we have a lovely team of 6 CHWs at Dakota County. It's actually 5.6 FTEs. I made a little typo there. They all hold a CHW certificate through the state of Minnesota, so they're all able to bill for services. In addition, some, but not all, hold different certifications. Similar to Nicollet, we do child passenger safety technician training, and they get certified as car seat technicians. We train them in a curriculum called Mothers and Babies, which is a mental health curriculum for parents. It's a 9-session during the first year of parenting. And then they also can do an asthma educator training and do home visits with our asthma program as supervised by a nurse. They speak a variety of languages, which provides great accessibility. 7 languages, and I guess 8, including English, are covered by our CHWs. Next slide. So some of the services we broadly cover are health education, outreach and engagement, lots of outreach, community resources, medical and dental appointments. So that's either helping make medical and dental appointments or helping people get connected into our healthcare system or dental system. And then overall addressing barriers to social determinants of health. Next slide. So our community health workers cover almost every program within our public health department. As I mentioned, they do work with the asthma program, so that we do have a program for school-age children. There's no income requirement around them who have asthma, and they qualify for a nurse visit to talk about medications, equipment, any sort of elimination of triggers in the home. And they can also refer to a CHW, especially if there are language needs, to help reiterate and reinforce that training. And as I mentioned, they do receive training through the state for that. Child passenger safety. So we do have a car seat program here. We provide car seats, including education to families who have straight MA or are uninsured. Or if they have a car seat benefit that doesn't actually cover car seats. So there's one provider that only covers like $90, I think it is. Child and teen checkups. So they work with our child and teen checkups program. They do outreach for that program. They do education, for example, at our early childhood family education, as well as they do phone calls for newly enrolled medical assistance participants to make sure that they're aware of their benefits, as well as how to get connected to a primary care clinic if they haven't already, and other resources inevitably come up on those calls. Directly observed therapy. So we do have one CHW whose primary role is in disease prevention and control. So she can help nurses with DOTs for active TB clients. She also does a refugee health work. So any new refugees who are working with a nurse to do their refugee health exam, they are automatically offered a CHW to provide resources, help them with figuring out medical rides, appointments, navigating our system. We also do falls prevention. So we work with our aging initiative. We have a partnership with fire departments in our county who can refer for frequent fallers in their home for older adults, and they can opt in to get a phone call. And CHWs make those calls to check in on the condition of the home, resource needs, other resources that we can offer them to help prevent future falls in their home and ultimately keep them in their home longer. A huge part of our funding as well as our work is around family home visiting. So Bree mentioned they do Healthy Families America. We use MESH as our home visiting model, and the CHWs provide tier 2 services. So they are under the supervision of a public health nurse and then provide services to the clients as needed who are kind of exceeding the capacity of the nurse they're working with and need more of the CHW skills around either language or just navigating the systems we have in place. Mothers and Babies, as I mentioned, that's a standalone service or can be offered with family home visiting, and we do have a CHW who does offer that 9-session curriculum to families. Reentry assistance, that's actually with our corrections. They work with recently released people from incarceration to get them to wrap services around them. So they do get a call with the CHW to figure out what resource needs they might have and how to get them connected. And then they also go to our mobile vaccine clinics. You can see on the top there, that's Fatuma at our vaccine clinic. I think she's on the call, so I got to shout her out. And we do outreach and offer resources at our, either we have community on-site clinics, school clinics, and then since it's Minnesota, we have a mobile clinic season because we can't be outside year round. So that's our mobile clinic up there. And then also WIC grocery store tours, similar to what Bree shared for Nicollet County. Next slide. So we do a similar funding model to Nicollet. We braid our funding. As I kind of have alluded to, our CHWs all have primary roles in different programs, but they're all cross-trained. And so that allows us to be a little bit more creative with our funding since they do cover multiple programs and services. So we do have some county levy allocated to our FTEs. We also have the Child and Teen Checkups Grant. MCH and Strong Foundations are both family home visiting grants. And we do have some revenue from billable services. As Bree said, not all of our services are billable, but we are able to recoup some cost through that. Next slide. So just a bit about billing. I know Bree talked about this, but this is a question we get a lot. So I thought I'd share how we do it in Minnesota. So under Minnesota DHS, we're able to bill under self-management education and training. So the caveat is they have to have a CHW certificate supervised by a PHN, and they're offering some sort of health education. So anytime that we're doing any education attached to a curriculum, to a health topic, car seat education, asthma education, mothers and babies, we can bill for that service. And within our electronic documentation, we actually have a way for them to indicate if they provide education, and then it automatically is a billable home visit. It's billed in 30-minute increments, and we're reimbursed $23.53 per 30-minute increment if the client has insurance, that is. So, I mean, just to give you an idea, from January through October of last year, we recouped about $2,500 through billing for home visits. Next slide. And then just a few of our numbers. I echo Bree and this definitely does not fully show the impact of the CHWs in our community, but this at least gives you an idea of the work that they're doing on an annual basis. So we did 758 outreach calls, which some of those can last 2 minutes and some of them can last 2 hours, depending on the needs of the family. And sometimes they're just like, wow, I've been waiting for someone to call me and ask me what I need. 264 home visits were completed. So that's either through family home visiting or refugee health. We interacted with 393 clients at our immunization clinics. We have a pretty robust immunization program here, so that's a really great way for us to get out in the community. We distributed 37 car seats, and then we interacted with 109 clients at different community outreach sites and events. So we do have regular outreach locations like our food shelves, homeless shelter, our domestic violence shelter, and then we also have events that we do throughout the year as well. So through those events, we interacted with that many people. And then I think my last slide is just information about how to reach me. So if you have any questions, feel free to reach me. If you want to read more about our community health workers, you can go to our website and just search community health workers. We have a lot of great information about our program there.
Great. Well, I especially want to thank Leah and Bree for joining us today. And I want to thank all of you for attending and taking interest in this topic. We do have some time for questions. We have about 15 minutes, and we do have one in the chat already that I'm going to lead off with. And I think either Bree or Leah, you could answer this, or maybe both of you want to answer. So the question is, how does the activity or service data you share address the percentage of people in the county that actually have a need for CHW services? So you could talk about whether or not you're able to assess the actual need within your county. And then what percentage are left without services due to funding, language access, partnerships, etc.?
That's a good question. I would say I don't have a way to quantify who would all be needing services. To be honest, like I said, the way we have our CHWs structured, or their work involves just connecting people to county services. And often that can mean most of the community, you know, whether you need a passport or driver's license, or you're needing food stamps. So that can mean a lot of people. So, but it's a good question.
Yeah, I wish I knew the answer to that question. I think we learn all the time that there's people that aren't aware of the services that are available to them. And if we could find a way to find them all, I think we would. The best way that we can address that is just continuing to be creative in the ways that we get out in the community, in the ways that we're engaging. But yeah, I couldn't tell you how many, but I imagine there are a lot of people that we still haven't reached.
Yeah, that's it's challenging. It's always hard to know what the need is, right? And the demand for services. It's hard to quantify. Another question in the chat is it's not really necessarily a question, it's more of a statement about the cost of getting a CHW credential. And so I wonder if you could speak to that about how you handle it within your county.
We in the past, we've had some grants that will cover the expense of getting a certificate. I will say those have been harder to come by lately. But I believe it's about $5,000 for us in at least the school that we're using routinely, because it offers a remote option for our CHWs. That's usually the cost of the full certificate course.
Yeah.
And this time around, we were fortunate to have, because we have a new community health worker who needed to get certified, and there was a scholarship opportunity that was released, and she was able to do that.
Yeah.
We would never make our CHWs pay for it out of pocket on their own. That's something we would incur the expense or hold off on them taking it until we can find funds.
Yeah, we have not encountered, everyone we've hired has had the certificate, although we don't require it. We do ask that they get it within a certain amount of time after hire. But I think when we have discussed that, we have talked about, tapping into any of the programming that exists at the state level around, CHW scholarships and the like. But yes, that would be how we would handle that.
Yeah, it's challenging. All right, I have another question. What public health model do you find most effective, and what does implementation look like for your CHWs? Anyone want to jump in with that?
Is there any I'm wondering if models related to anything specifically. I know for us, following an evidence-based home visiting model has been very helpful. I think they kind of, it just provides a lot of structure and support to home visitors around what can be offered to families, which I think is helpful. So Healthy Families America is all I know in terms of a model for home visiting, but maybe the question is getting at something else.
Yeah, can you just talk a little bit about the kind of structures that it puts into place?
It has like reflective practice requirements, so weekly meetings with a public health nurse so that they're engaging in reflective strategies that they would be using with their families. There's a larger community of practice. We're not the only agency that does HFA, so they're able to engage with other home visitors. They have books, like heavy books, full of things to do with families that they take with them so that they can do hands-on activities for parents to learn how to engage their baby with average household items like yogurt cups and some rice. So it's nice to have something to utilize, although I will say like HFA sometimes gets a bad rap, and I don't know if this is true of MESH, but there's a lot of documentation needed. However, I think that's just used to support the fact that it's an evidence-based model ongoing.
I think I would just add that I think what has benefited us is having multiple models and trainings that our CHWs can lean on. So yes, we love our home visiting model, but at the same time, not all of our CHWs do family home visiting. And so they can rely on their training. And even if, let's say, they're in a home visit and they're not necessarily using mothers and babies training, but they're having a conversation about a client's mental health, they can lean on those skills that they learned, or having a home safety discussion. And maybe they're not doing a full car seat visit, but they have that training to talk about it in a way that's, they feel confident, and then also will give good information to the client. So I think it really benefits us to have multiple curricula we're using, multiple models if we can, although that can be a pretty heavy training burden. So that will, sometimes it takes a while to get the CHWs up and running with all of them. But I do feel like they do lean on those trainings, even in situations in which they're not necessarily fully implementing a model.
Yeah, great. I have a question about outcomes. Both of you mentioned, like the things that you're measuring don't really reflect the full scope of the work that's being done by CHWs. And so I'm curious about like what are some of the things that you wish you could be capturing or you wish you could be measuring that are just harder to capture?
I would say the work outside of the structured home visiting model is the part that I'm struggling with. Is sometimes connecting community members to the county can be one phone call. Sometimes you're meeting more routinely with community members ongoing, and so any sort of outcome that happens with those interactions are something that we're not very effectively capturing, because there's so many reasons why someone might be coming to us. So I think there's some thinking around that I'm doing. But like I said, there is some work happening right now to develop some more routine CHW outcomes measures that I'm very much looking forward to.
Yeah.
I think, that's a really good question. And I'm thinking a lot about this. And I think, there's a couple things I know we probably will never be able to get data for. Like the first thing that came to mind was like, how many people did we get enrolled in, in insurance or get, and that's just not data we would readily have. But I imagine it's a huge number and would really demonstrate like how many people were getting access or helping get access to our healthcare. And just thinking about, there's so many, yes, we have formal clients that we do home visiting with, but like I said, we're in the community. We're doing a lot of, just kind of informal follow-up, like, hey, they asked a question, I got their number and I called them back, but I'm not necessarily like documenting that. I mean, that happens so much in like just the informal, because they become trusted members of our community and people know them. And so they'll walk up to them and say, hey, can you answer this question? Or can you help me with this? And we don't document that super well. And I don't know exactly how we would. But that is something that often comes to mind for me, because it is it's little things, but that add up to a lot.
Yeah. Absolutely. I'm just going to pause for a second and see if anyone else on the panel has a question. We are getting close to our time here.
I actually have one. I know, Bree, you specifically talked about some of the services that CHWs work within the health department outside of direct care. And I know, Leah, you some of you, the CHWs who work in your department do the same thing. So I was curious if you could talk a bit broader about non-direct care services. So thinking about that population health, foundational public health services that some of the CHWs who work with you are engaged with.
Yeah, we try to keep their time, part of it set aside for some more of the foundational public health population level interventions. In the past, that's looked like Minnesota Student Survey is one of our foundational sources of data in Minnesota, and in our local public health agency, and it was showing some alarming rates of anxiety among Somali girls. And so our CHW said, I want to do something about it. So she found an evidence-based curriculum, we talked to the schools and worked with the local middle school so that she could offer it there. So that's kind of an example of community identified needs that we try to still have time for them to address. We're just finishing our community health improvement plan, so I imagine there might be a few more things that come out of that our CHWs will take on some sort of population level intervention.
Yeah, to be honest, I spend a lot of time, we do a lot of direct service, and but I will say within our department especially, people are always trying to ask me for ways that they can use CHWs either for their input. So a lot of them sit on different committees within our department, including our ethics committee, our IDEA, which is what we say for inclusion, diversity, equity, and access, for different strategic plan objectives, because they have such a beautiful perspective because they are so embedded in our communities and can really speak to community need. And I should say, anytime we've launched a new initiative, like for example, falls prevention that I mentioned with the aging adults, that's been around for a year, and they were huge in implementing programming as well, and what makes sense, and how's the best way to reach people, what do they feel comfortable asking, similar to how we just launched asthma as well. So I would say that's been the biggest impact, at the more population level, is really kind of informing some of our practices, and working internally in some of our work groups to move us forward.
Great. Great. All right. Well, we are just about at time, and I want to give people a chance to log on over to the other CHW presentation that starts in 1 minute. So I want to thank everyone for attending today. I especially want to thank Bree and Leah for joining us and sharing their experiences in their counties. And we will be sending out a link to the slides and a recording of the webinar. I know there was a couple questions in the chat about whether or not that would be shared, and it will be. And then, of course, please feel free to reach out if you have additional questions or comments. Thank you, everyone.